All right, welcome back to AI for Healthcare. I hope you're having an awesome time so far. Next up, we have a panel titled Reducing Fraud, Waste, and Abuse with AI. Please join me in welcoming our panelists to the virtual stage.
All right, thank you so much. My name is John Hamdorf. I'll be the moderator today, and we are going to start with introductions. So let's start with Richard Stevenson. Please introduce yourself, sir.
Thank you, John, and welcome everybody. My name is Richard Stevenson. I'm Chief Executive of Redbox, a company that provides a platform that supports AI initiatives in the insurance sector, emergency services, first responders.
Fantastic, sir. Thank you for being with us. Nicole, please introduce yourself.
Hi, thanks for having me. My name is Nicole Neumarker. I'm the Executive Vice President of Innovation and Development at Cotiviti. We are a provider of healthcare services, largely in the payer community, although we work a lot with providers as well.
Fantastic. Thank you for being here. Stephen Wong, please introduce yourself.
Hi, I'm a Johndorf Endowed Presidential Endowed Chair at Houston Methodist, Associate Director of a Cancer Center, and also Chief Research Information Officer. I've been with Houston Methodist for 15 years. I have altogether more than 30 years experience in healthcare industry, medical imaging, and also academic medicine. Before I came to Houston Methodist, a professor from Harvard and UCSF. Thank you.
Great, thank you, sir. And I'm John Hamdorf, the moderator today. As I mentioned before, I'm currently the Chief Operating Officer at UnitedHealthcare Community and State Plan of Kansas. It sits over the Medicaid and our DSNP programs. Before that, I ran Kansas Medicaid for 2 years, from 2017 to 2019 for Governor Collier. And before that, I was in healthcare IT for about 15 years. I do have some academic training, did my PhD work at KU Med and health policy and research. So with that, we had a great panel today. Let's not pause for a second and get on right with the first question. All right, our first question and topic. It's been a tough 12 months. Has AI played a supporting role during COVID? Let's start with Nicole. What are your thoughts, Nicole?
Sure. So we have a relatively extensive set of healthcare data that we leverage in most of our solutions. And COVID was a really interesting opportunity for us. We didn't normally interrogate data in this way, but it gave us an opportunity to interrogate our population health data in entirely new ways. And so we spent some time just running all kinds of models, trying to understand what was going on. This is largely before the pandemic really expanded. There was much data in the industry that we could read from. And what it helped us do was it helped us really solidify our pipelines of AI into our solutions and harden what we're doing, because we were able to kind of explore the edges. So we found it a really interesting exercise in trying to rationalize how we use AI in our solutions, because it was kind of on the outside of what we normally do. And then the second thing was we built a tracker that had some predictive capabilities around where potential hotspots were going to be, because our data covers most of the United States. And so that's on our website at cotiviti.com, but it's something we keep up to date now because it's been useful for us. Yeah.
Great, thank you for your thoughts. Steve, what are your thoughts?
Sorry. We have the same experience as Nicole. I think there's an opportunity for us to look at the accumulation of data warehouse we have, look at the model. I have a slightly different take on these AI things. A lot of publication, actually, I think probably a couple 100,000 papers published last year. Amazing, the number of the academic work. But reality, if you look at a lot of these papers, a lot of predictive models are very poorly reported, in the sense that they are not validated, very high risk of bias. Therefore, it's very hard to repeatable. So whether AI for me is still open questions, whether it have impact. The area that I see a definite impact will be in the X-ray and CT, using AI to deep learning to actually identify. But then again, it's kind of oxymoron in the sense that we have very good diagnostic. We don't need CT X-ray to AI, but those are very good tools for monitoring. Once you have that, we use that. So that is one area I think the current deep learning is successful. I organized a couple of journal issues, and on the paper I saw most of them are really about public outbreaks, database tracking, all these things. A lot of people, they say they're using it in clinical prediction, getting all different parameters, vital sign, age, comorbidity, all kind of thing, right? And all different have different take. And so far I haven't seen any conclusive result. Of course, is different hospital reach a different conclusion basically, and result. I'm sure you survey 10 hospitals, they'll give you a different conclusion how to apply the tools. So far is so, and the area is still evolving, but in terms of imaging area, definitely make a lot of headway in the area.
That's really fascinating. I spent a couple of years too in the imaging space, and that has been evolving ever since the early 2010, that area, this idea of AI and imaging to help re-engage the radiologist and other folks doing the reads at a deeper level with patients, and providing some supplemental support there during the reading process and the analysis process. Those are great comments. Thank you, sir. Richard, your thoughts?
Yeah. So we've probably got a slightly different angle on this. So the platform that we deploy effectively captures voice, video, and screen in real time across an organization, and then feeds that into AI engines. So that's the part we play. And obviously with distributed workforces, people sheltering, working from home, we've seen a real explosion in organizations looking to see how they can best track what's happening with their customers and also their colleagues, their employees across the whole of the customer journey. That could be remote consultations, for instance. It could be claims. It could just be general sales calls as well. So across the whole piece, we've seen a real change in that regard. And there's a distinction between two different types of organizations. We're seeing some organizations who now, in terms of their future working practices, are trying to embed AI across the whole of the organization. And we're seeing an awful lot of pretty straightforward point solutions, I would say. So the point solutions tend to be more around efficiency gains. So where you want to get full coverage of particular calls, rather than using manual intervention and people just listening to calls, you use AI, and you're getting, the kind of numbers we've seen are from 5% manual intervention up to 70, 75, 80% using AI. And the other interesting fact that we see in terms of AI and culture, and my background, I ran a German insurer for a couple of years where we did have insurance, and we did have fraud issues at times, is that if you tighten up on culture and governance, then clearly you start to get many more false positives, and you have to deal with the cost of false positives. Whereas AI doesn't really do that. AI gives a much more objective measure and just consistently assesses the risk levels in the business on particular cases. So in that regard, we've seen quite a few organizations starting to deploy that kind of capability.
Very interesting, sir. Yeah, and it's interesting as we talk about AI. I've always kind of looked at AI in my experience over the past decade or so as, there's the machine learning side of it, but then there's like the process automation side of it, and somehow this definition of AI is nebulous. We don't know exactly what it is, right? And just like you guys have mentioned, are we using it for identifying? Are we using it for predicting? Does it introduce bias? Does it remove bias? The quality of the data sets that we're providing it, that'll obviously affect it. And any other thoughts on those comments?
Actually, interesting. I was in another panel asking that question. People ask me the same question. I think if everybody's mind, I think the AI right now in healthcare, I kind of think about it's a free bucket, right? One is the business, try to reduce all this administrative overhead. That's what Richard has done. I mean, it's automation, the process. We spend our money. We spend a couple of $100 billion just in administration. Right? This AI can do. The second part is Richard also mentioned it about the area of the telehealth. I mean, it's going. I mean, we stay. You will more telehealth, more home care, things like that. And these are the area for me, more or less a low-hanging fruit. I'm telling you, that can be done. I can see it can be done. Giving enough money, you can get it done. The third area, we are in healthcare because we are interested in improved health. So the more important is how to direct it into clinical decision making, how to dealing with clinical intervention. And that is the hardest area. The reason why, the first two areas, you probably get away from validation, get away from clinical trials. In the third area, touch on human, man, FDA come down to you, man, you better do a proper clinical studies. So that is really a roadblock for a lot of people. But this is the area that we are in healthcare for, really impacting the patient care using AI. There are some inroads in the area, but it's hard. I think this area that I don't see that much. I see a lot of AI right now applying. Even people come to our hospital, mostly are about improving the business process, improve the telemedicine. Very few of them dare to touch on I can help you to reduce over biopsy. I can help you to reduce over surgery. No one dare to say that. I think that the area is still missing right now. The first two is doing well. I think we get a lot of low hanging fruit, bang a buck, save a couple $100,000, a couple $100 billion. I think this is a good way to do it.
Thank you. Any other thoughts, Nicole? I saw you shaking your head as well too. Any final comments?
Well, both of that. So we've segregated our AI at this stage between exactly what you've alluded to, Stephen and Richard both, which is sort of an operational, where does AI provide operational efficiency and bring cost out of our processes? And so we have an operational AI area that deals with all the use cases to do with people, process, how do we take time out of that flow, whatever, because there's plenty of cost in healthcare. There's plenty of friction. There's a ton of friction in healthcare. And I think AI has a real promise in reducing some of that friction for a couple reasons. And then the second area we have very distinctly is in more predictive AI, in trying to isolate a couple different areas, like what is a gap in care that we can isolate based on a longitudinal record of a patient? Or what is the best next step in trying to ensure that we're trying to get that person closer to the kind of end state care they need? So we've bifurcated those, and I think we'll bifurcate them further. I personally, I think AI you're right, Stephen, there's a lot of low hanging fruit. That stuff's left the lab. There's still a lot in the lab. When I say lab, I think AI organizations that we've either acquired or engaged with are very much lab oriented and not very much value oriented. It's not very clear what they're working on. You alluded to that in the very beginning, Stephen, about all the papers coming out, not having a lot of clarity about how you can replicate those use cases. So we've been very use case driven. What are we trying to solve? How do we solve for that? And then we focus in that way. And that's where we've been finding more value versus it just being the constant science experiment, which I think, like all tech, it's very easy to spend a ton of money in technology and achieve only kind of a dubious value. And so we've been fairly ultra focused in that way at Cotiviti.
I think those are fantastic comments. I mean, just as an operating officer and someone who's been in operations forever, it always boiled down to the holy trinity, if you will, people, process, and technology. I'm investing in technology because I want more efficient processes. I'm investing in policy so I can use and leverage my people in a higher value function. I couldn't agree more with your comments. It was great. Why don't we move on? Oh,
I'm sorry. I just think since you're coming from insurance company, sorry, I want to pick on you. we have been talking about healthcare, right? Hospitals. Since you're from insurance, I think that one area that I haven't seen much, maybe you guys doing that, I don't know, is, prior authorization. This is what insurance does. Right now, the country probably got about 70, 80 million prior authorization hit the insurance, right? And then you got a free tier, right? You have some sort of low-level people kind of screen it, and then physician assistant finally hit the doctors, right? But so the problem is this process itself. I think it will create a lot of waste and also unnecessary costs, because the first level people you are dealing with, they look at a checklist, not much intelligence into it. I think you can apply some AI into it. In fact, right now, it's the whole. Last I checked the labor website, only about 720 doctors working in the prior authorization for the whole country. Okay, so that cannot scale. Doesn't make any sense to me. I wonder what's your take on it. I'm sure you guys think of it already. So there's a reason I ask questions.
No, I love the question. It's fantastic. I would argue that there's still a component of I before we get to AI. So there's some things on prior auth that have no business being there, that cost twice as much as anything that we're saving. So that's one thing we're doing, is trying to identify those types of prior authorizations, at least in my market. You know, we looked at like PT, OT, ST. We're like, why are we pre-authorizing these? You know, let's just run with these. All right, those are going to be okay. We're not worried about that. There's still going to be some PA throughout the cycle, you know, in certain nuke med, those kind of imaging things. But I agree with you. If there's a way to streamline that, that's better for the entire system. It takes, you know, onerous time, you know, out of my organization. It takes, you know, time out of the hospital's, you know, staff to be able to do that. They can focus on working with the patient, doing higher value things, like I mentioned before. So yeah, I think there's a real place. I think that, as we mentioned before, there's probably a lot of low hanging fruit that we can just do because, you know, the finances, you know, support it. But then once we get into the things that we have to do, let's try to do things that have we do smarter through AI and other technologies. Great comment.
No one working on it. I was surprised. Maybe this opportunity for your organization to think about it.
You got to remember, I started off consulting in the hospital space and with Cerner and other places, helping hospitals become more efficient. So when I looked at some of our processes, I'm like, whoa, wait a minute, why are we doing this? we gotta rethink this.
You know, guys, the big piece of payer is the biggest part.
Yeah.
Right. Your topic is about waste, fraud. I think this is the area I will focus on first.
No, it's a great one. And actually it really leads into our next question extremely well. So let's kind of segue and continue the conversation. So how can AI be used to prevent fraud, waste, and abuse? Provide examples. So I haven't heard from Stephen, probably the latest. So, or Richard, I'm sorry. Let's start with Richard on this one.
Yeah, I mean, we're involved in quite a significant number of AI initiatives. And I think just to take it back a step, first of all, when you look at the foundational piece, because these kind of conversations are great. And then many people maybe who are listening to this will go back into their day jobs and realize that actually one of the big issues they've got is that they don't really have access to the data they need to fuel AI. It's fragmented, it's fractured, it's poor quality, it's inconsistent. Maybe it's broken up between, you know, the sellers of the products, the provider of the products, the consumer of the products. Certainly that was the case that I've seen in many instances. So I think there's you know, a piece of work to be done around the whole cleaning up of the enterprise organization, because, you know, if you're dealing with some of the issues we're talking about in terms of waste or fraud, but you're still effectively just dealing it in small silos across the organization, you're going to gain some benefits from doing that, undoubtedly. But the only way you'll do it is really to take an enterprise-wide, you know, following the full customer journey approach. And there are a few organizations we're seeing doing that, but not many at the present time. What we're seeing is people trying to address, you know, areas such as, you know, the inefficiencies, using AI to look at optimization of processes. That's absolutely happening. And what we're not seeing so much of, although we're starting to work now, and you probably know these organizations with the likes of the customer experience vendors, to get down to a point where, and probably the easiest way to, well, not the easiest way, but one way to avoid fraud is actually really, really understanding the motivation and the sentiment of the customers, and really profiling those individuals in a way that they haven't been profiled prior to this, and getting more down to a personalization of service and of contact with customers. So we're seeing quite a few organizations start to do that. So effectively then they're dealing with, you know, John or Richard or Nicole. They're not dealing just with another policyholder or just another member. They're dealing with you as a person. So we're seeing quite a few initiatives in that space as well.
Great comments. Nicole, let's get your thoughts.
You know, Richard, he keyed on the very most important thing I would agree is one of the biggest challenges, which is comprehensive data. I mean, and Richard, you've alluded to a couple things. One, it sounds like what you're working on in your organization is filling in some of the gaps where we don't have, I mean, so much of healthcare data is not actually in systems. I know in our world, we think of claim systems or EHRs. That's where all the data is. And it really isn't. There's data, that's probably 25, 30% of all the data. And there's 75% that's just sitting in conversations, in Fitbits, in, you know, Apple Health activities. So making that more comprehensive. But for companies like mine, where we don't have yet access to that type of data, we have to deal with what we have. And what we have starts with claims, starts with medical data, and rationalizing all of that has been a massive investment for us. I think, Stephen, when you talk about why aren't you going after these things, there's not a lot of, let me just say, I don't believe payers have a lot of reason, or insurance companies, to be incentivized to integrate their data in any way. So companies like mine, we sit in the middle, working with payers, working with providers, and we spend a lot of time right now investing in just rationalizing the data before we can even begin our AI models. We started our data rationalization exercises probably 4 years ago. And just now we feel like we have a comprehensive data set that is meaningful for AI, because AI is voracious in its consumption of not just data, but in labeled data. And so we are constantly trying to label, articulate, and make clear that data. I think we have about 6,000 attributes on our patient data today. And that gives us at least a foundation on which to then interrogate and ask the questions. But that's a lot of work. It's a massive investment, and you have to be motivated. And again, know what your value is on the other end. Otherwise, everyone gets tired at about the 1 or 2 year mark, and they're like, why are we spending money on this? We don't see what's coming out of it. And that ends up being my job, is largely trying to explain, okay, we're making this investment for this foundation to drive these capabilities later. But I think data is definitely the first, and then, you know, there's several other challenges, but I think I touched on a few of them.
Oh, you did. Steve, let's hear from you.
I think I all agree with Richard and Nicole. I think I coming from a hospital side, I probably take it a different perspective. I try to focus on patients. Because business side, you guys knows much better, insurance, all these things you worry about. But one thing about patient care is, I think this country we are facing is over medicine. We all know that. We pay double than our peers, but yet our quality of the service and mortality is one of the worst. So over medicine, in the sense that for many reasons, very complicated issue. But I'll give one example. We in cancer, we do a lot of screening. This is the area actually, I think over screening. Very dangerous to say that people got killed. I know it's not a very popular way to do it. I know people say, I want to catch, screening will help you to catch something, you know. But the point is, you probably catch one guy and then you get another 100,000 guys to suffer to do unnecessary biopsy. So it's a matter of rationalize kind of the cost benefit, really. I'll give you an example, like breast cancer screening, right? We do about 30, 40 millions per year, something like that, okay? And we got about 10 to 15% false positive. It turned around is about 700 to 750,000 patients. They are unnecessarily biopsy. And not even talk about, you know, you 700,000, if you know medical procedure is not absolutely correct, right? So we get about 99% we think is very good. So we miss 1%. Do 7 beside biopsy of this 750,000, and then we get a 1% of those, I think maybe 8,000 people go for surgery. And then you can see why it's going down, right? Is if we can using AI, for example, make the screening more accurate, more precise, reduce the false positive, while keeping the true negative, the sensitivity very high, so you don't miss anyone on that condition. You reduce your false positive, then you actually do a lot of things good for the patient. It's a win-win-win. You save cost, you help the patients, and you don't hurt anyone. In fact, a lot of time, the paper published, patient go for biopsy, and you find nothing, they scare. They worry about you don't biopsy correctly. It must be something, you do some procedure on me. So these are the area that I think AI can easily do. And we are lucky in the sense that with EMR, with PACS, all these things within the big hospital health system, all this data there, the raw data there, putting together comprehensively is not that much a problem anymore. We have raw data set, now it's built a data warehouse on top of it. It can do a lot of wonderful things. I think insurance companies have a motivation to work with providers on this, because they will ultimately help your bottom line, provide you better service. Anyway, this is my one example. The over medicine. In fact, we should less medicine, more value. We should less medicine, adding more value to our patients. Right now, we are not. We're doing reverse.
I couldn't agree with you more. I mean, there was a strong reluctance for active surveillance for some of these things. It was just, we got to do something. So let's do something.
Yeah.
Versus let's just see what happens, especially in, as you mentioned, like urology and, breast cancer and those kind of things. If we don't hit them fast enough, let's hit them again and realize that we're actually pumping radiology and things that aren't good for the person, as part of the treatment. Great comments there. I think what's interesting to that too, you mentioned data warehousing and accessing data, and Nicole, you mentioned like Internet of Things data, and we haven't said it yet, but HIE data is out there, and some of them different formats, different structures to them. And then we try to bring in genomics, and we really try to do personalized medicine. Do you think that we are like data hungry without knowing how we're going to use it once we get it, or do you think that we just go ahead?
Yeah, I can comment from our side. What we've seen, and I do worry about whether people really, careful what you wish for. We've seen a big explosion almost in the last 4 to 5 months for real time. Mm-hmm. People just want real time everything. And often, again, something I think mentioned it before, it's not just the raw data, it's the metadata that's associated with that actually makes sense and gives it context. So everybody wants to be able to have real-time interdiction into various processes because they think by doing that, they're going to stop bad things happening. But they have their existing processes. So if you actually link real-time analysis, real-time AI into a standard process, and that starts to fail you at any point in time, how do you revert back? So that's what we're seeing more and more. It's the volume, but it's also the fact people want it now. They want it real time, and I don't think they really do. But that's one of the big themes that we're seeing more and more. Can you deliver this data in real time to us?
Yeah, the real time pressure is on us as well, for sure. A lot of our systems. I was just in a meeting where I was trying to justify a massive upgrade in some of our infrastructure, because basically it's the real time demand is requiring these massive investments in hardware, really, and combined stacks. But one of the things that, back to what you said, Steve, about solving for true health and value versus just cost and transactions and medicine, we did some studies where we looked at longitudinal data of patients, and AI was very instrumental in helping us build models to be predictive of when and if someone would become diabetic. And diabetes is, just like I'm with you on the breast care like all the analysis, it's significant, but diabetes is a massive cost too throughout the United States. And being able to intervene in that sooner before it really gets costly and provide patients with the sort of interventions we need to stop it from getting out of control. That was a really promising model for us. We couldn't have done that without AI. We couldn't have done it with the right sets of data too. We take data not just from one part of our business, but we aggregate it from other parts of our businesses. And then we have this sort of side business in retail that's provided some really interesting demographics across our patient data, because we can see in what geographies people are buying what types of things, and then overlay that to how, if you see a lot of purchasing of, let's just say, low cost stuff, or things that might imply that generally health is at a lower quality, that has implications then for what we're seeing in the healthcare data as well. So we can overlay those things. So you're right, having too much data, be careful what you wish for. When you have a targeted idea though of what you're trying to understand, that the richer that data is, you really can start filling in the gaps, and you stop looking at Swiss cheese and you can fill in the holes. So it is really instrumental in that way, for sure.
I totally agree with you, Nicole, but I work on a couple of research studies. I tell you, behavior is the hardest thing to change. I don't get my kids to understand what to change their behavior. I mean, that's tough. I mean, but I totally agree with you. You have to change behavior, but I think that changing behavior is bigger problem. You talk about not just a cost incentive, but it's also education, culture, many other things. But it's an area that is very important. We have a couple of projects on that. It's very, very tough. Have a patient, even the after surgery, they still eat like hell. It doesn't matter. You scratch your head. Why, right? So it's hard. But one thing I would say that this is not. We are not data. We are often abundant of data. In fact, right now we have a lot of junk data, I call it.
Right.
The reason I say junk data means that data, you give it to me, I don't know what to do with it. It's for me, it's junk, it's useless. Just like I got email, all the email, I mean, I'm sure all email carry one message, but for me, it's junk email every day. I mean, I don't read them. So the question is, we should have as a healthcare professional, we should ask a question. What problem, I take an engineering point of view, okay? So what problem we want to solve? Once identify what problem we solve, then we find out what are the data that are helpful to solve the problem. I will ask people who, another IT people come and ask for big infrastructure, ask you, what problem you want to solve, tell me, and how you're about to solve it, right? Not just trendy, everybody have big data, lake, all kind of thing, put it together. Then what, tell me, right? That was the purpose of doing this. So you need to ask, what's your return on investment? You have to prove the case. It's a business, no difference. So, I mean,
absolutely.
Go ahead, John. Yeah.
No, I think you're spot on. And you mentioned something that I was hoping we'd get to is how do you change that behavior? And without the thing that we've been talking about a lot of individual information. What we haven't talked about is community. Like what is the infrastructure in the community that these people in that we're trying to chase behavior? Let's say we're trying to get somebody to go to a grocery store versus go to a Quickie Mart or something like that. We see everything about them, say, wow, this is gonna be good for their blood pressure, good for their cholesterol. But then we realize they live in a community that doesn't have access to a grocery store and no bus lines to be able to get there. So, I mean, I know we keep getting this data question bigger and bigger, but I didn't think we'd mentioned communities yet and where people are living.
Actually, we are working with Texas A&M on the rural area Texans, on the different counties. Texas is huge, right? We think we are one country. so we have many different areas. We try to reach it. I think that's the area technology can help. Really, technology can help. The digital health technology, if you have good digital therapeutics, simple one, not very crazy one, okay? Very simple, straightforward. Measure one thing, and you can deliver to them. You can reach that population. I would suggest there's no generic. Diabetes probably too broad. I think diabetes is big problem. If you focus one particular area, like look at, I don't know, I mean, let's take a cancer, lung cancer. You want people quit smoking. We know that smoking, you have high chance of lung cancer. So, and the problem is when you quit smoking, you eat a lot, right? Because to compensate the pathway, the molecular pathway, to compensate that sensation, to eat, so increase weight. So when people quit smoking, do you have any diet management program for them? It's a simple thing. You know what a grocery, what nearby, and help them this program so they don't replace the quit smoking with eating and increase weight and causing all kind of diabetes problem later, right? So this is these are the things that you can look at it in the whole picture. I tend to think about focus a problem and then zoom in that problem. If that problem can solve, and then you can see you can generalize the problem to other problem, getting bigger and bigger. We try to take a diabetes. Diabetes is actually big, just like Alzheimer's. Alzheimer's now is on the rage, right? Everybody talk about Alzheimer's. Government put a lot of money, but Alzheimer's is a very difficult populations. People at their age, they all kind of disease, all kind of problem in the brain. It's very hard even tell them apart. So if you can focus one area and get the area working, start say insurance company, you target lung cancer population. If you can improve that area, and you can see can apply to other cancer patient or other stroke patient or other things. There's something to think about.
Yeah, no, those are great things, and unfortunately, we'll have to move on to the next question. I know we want to get through these. There's a lot of good things to talk about. Let's go to perfect. So somewhere between 70 and 230 billion goes into fraud, waste, and abuse annually. So what could recapturing that loss mean to the healthcare system? So I think that works into well our conversation that's going on right now. We talked about where we need to make our investments or how we need to approach things. So let's say if that money comes back into the system, where do we invest it? What do we do with it? Let's start, Nicole, let's start with you.
Sure. I'll key off some of the things that we just talked about and both Stephen and Richard alluded to. I think, Steve, I heard you say sometimes medicine isn't the answer. Sometimes changing their habits or changing their environment or other things are the answer. It's not always just straight up medicine, tests, et cetera. We did a study, some longitudinal studies of a particular individual. We had this long study, and what we saw was that what they actually needed, the healthcare problem they were having, was not that they needed better healthcare. their healthcare, their overall state of health had gone down because they'd become homeless. Yeah. And so the first order of business for that individual was actually finding them a place to live. Right. So back to your point about community, John, sometimes the first answer isn't send them to the doctor. The first answer is find them a place to live, find them a place where they can get good, get quality food or get taken care of or a roof over their heads. And then we move on to the higher order business. And so when you think about healthcare at large or wellness at large, I think that money can go back into both taking care of those other aspects versus sending them right back to the doctor or giving them more medications, or the quick answers sometimes aren't always the real answers. And so in an ideal state, we would take some of that money and put it back into those things that really truly drive wellness versus the things that just drive help, office visits, if you will. I don't think office visits are always the answer.
No, fantastic comments. Couldn't agree. Richard, yeah, you have
look, I agree with that 100%. And one of my concerns, I guess, and now I'm ex-insurance now, so I can probably say this, I no longer work for an insurance organization, but, I think there's a big onus to really, really understanding people's personal circumstances, their life journey, where they are, how they progressed over, say, a 6-12-month period, what may be best for them, and what may be best for them, maybe some form of intervention. It may not be, maybe something very, very different. I don't think there's anywhere near, and I'm obviously talking more from a European perspective than a US perspective, but I just don't think there's anywhere near the focus. And it's hard to say this, but I think on the insurance side, I don't think it's always top of the agenda to be thinking about this stuff. There are other metrics, as we all know, that drive some of these organizations. So I would agree 100% with Nicole. I think that's where we should start. And start doing much more in that space, first of all, with some of the savings. And then, for sure, undoubtedly, in terms of actually provision of care, then we can move into that space. But I would start, first of all, more from the lifestyle and the community side.
Great quote. Steve, what are your thoughts?
Actually, I don't know what 230 billion come from. The JAMA published a paper, 2015. The estimation is 760 to 930 billion dollars. The number is much bigger, much bigger. Right. Almost one third of our healthcare costs are waste and fraud. Anyway, this issue, you can look at the paper. There's a lot of statistics on it. Yeah. You talk to academics, always like to quote numbers. I'm sorry about that. But if you ask me, I totally agree. Housing is a major issue. On the other one would be education. We way underinvest our education. I think that better educated person, they better take care of the healthcare. So these two areas we definitely need to improve. The money saved, you save about $800 billion. You can do a lot in education. And this is one thing. The other thing is we also, most hospitals, they have a charity care for the needy. And I think the money saved, unfortunately, we still have 12% people uninsured. Our hospital actually has routinely, we give $250 million out as charity care. I think this money can be saved for these people, needy people who cannot pay healthcare still. We are not covered them. This is for humanity point of view. I think we should do that. So if you ask me a question, it's really more education, more housing, and then more charity care. With the good money saved, with the good use of charity care for the people who need it.
Yeah, I think these are all just spot on, comments. I think one of the interesting things is, I'm in the Medicaid space, which it's growing and growing. Half the kids born in our country now are going on to Medicaid. It's interesting, Medicaid is pretty archaic. It's, it was developed in 1965. That legislation still sticks around, where Medicaid actually prohibits the spending on things outside of medical care. However, the adoption and inception of managed care organizations into those markets has given flexibility through in lieu of services and value-added benefits that allow us to address things like housing, food insecurity, a lot of those social determinants that we're talking about, transportation issues. States have had to proceed doing that through what they call 1115 authorities, which essentially says I'm waiving the current federal regulation because I think this model worked better if I invest in housing and if I invest in non-emergency medical transportation, I invest in community engagement. We're not quite there yet, though. It's still an evolving, ecosystem that we're working through. UnitedHealthcare has made a ton of investments, as well as some of the other, MCO leaders within this space. We see states like North Carolina, which has really taken an aggressive approach through their 1115 waiver, which is commendable. And more, I think you see this adoption of, hey, you know, let's spend our money here versus there. There are going to be technical issues when we talk about actuarial tables and we talk about, you know, rate setting and capitation and all that nonsense that we spent so much time and effort and energy on when, you know, really, we all know what we need to do.
Right.
It's just, we have to cut through all the tape to get there, right?
Yeah.
Thoughts?
Yeah, I mean, you've just stepped outside of probably most of the boundaries of the three of us in terms of our effect and implication. But to draw it a little bit back there, John, I definitely think when you talk about education, how do you know that education is actually solving the problem? I 100%, I have educators in my household that are educators for a living, and Steve is exactly right. And measuring that impact, metrics are in and around and all over, but I think AI and the assessment of data really helps us understand where education is making a significant difference and can help cut through that red tape. Because I think you're right. I think deep down we all know, but government loves to have its metrics and measurement and know that the investment it's making is actually making a difference. And so I do still think that us taking our data swamps and turning them into something meaningful, because I think we do all start with swampy data, not lake data, not clean, pristine, beautiful data, but swampy data, translating that into meaning, and then showing, yes, in fact, the dollars invested in preventative care and taking care of community actually saves us a ton on the back end when it comes to these healthcare problems. So I still think that information is going to help us get out from under that, but 100% agree with you. 100%.
One thing, Nicole, one thing you can measure the education rate direct way matrix, PKI, is really about all the ranking we have. Our school consistently rank very low in all measure against all developed countries. If we can invest the money to improve that ranking, it will show that.
Yeah. And you know, and maybe I was slightly critical on the insurance side, but it was certainly one of the things that, that my ex-insurance employer did. And we had about 6 million UK customers as well. So we would create communities. So we would analyze and look for people who were sharing similar experiences. And it wasn't just profiling on age and geography and all the rest of it. It was a bit more detailed than that. And then let those individuals share the way that, so rather than telling or educating through more formal steps, this was just sharing in the community how people were addressing particular issues they had. Now, that doesn't necessarily mean then you get best practice or you get best outcomes, but providing that type of network opportunity for policyholders or for patients, I think, you know, that certainly had a very, very positive outcome for many of the policyholders of that particular organization. So I think there are a number of different ways of looking at it, but I think you're right. Tracking cause and effect, and being able to access, you know, the real metrics on whether this is working or not. I think that's a little more difficult.
No, great comments. Great comments. Let's move to our last question, because this is the fun one. This is what one of my professors used to call the bring and brag. You know, this is a time where we get out our crystal balls and say how we're going to fix the problems of the world. So what is something that you are thinking about for the next year specifically when it comes to your AI initiatives to solve all these darn problems that we've been talking about today?
Steve,
who wants to go first?
Yeah, you've got this, Steve.
Let me go first.
You be the man.
I have a meeting to run very soon, so sorry me cut off earlier. But I think to do the two things I want to do. First thing is, as I say, less medicine, more value, and we are doing that. We take advantage of comprehensive data we have in the hospital, try to get more precise index in all things, in cancer, in stroke, in Alzheimer, in all these things. That's very important. If you get a more precise index, you actually reduce a lot of unnecessary procedure and harmful to the patients. That's one thing. So this we have a couple of systems. We already done the clinical trials, and we try to implement it eventually. So the one thing we are doing that. And the other one is, actually I'm giving a talk on one of the example case study in the AI for two of them actually, stroke and the breast cancer. The other one is actually we're trying using AI to actually we have to how do I say to overpower the physicians. We do a lot of physical examination. We do a lot of post-surgery physical therapy. We do all the post-treatment diet control for the chronic care diabetes patient. All this require a lot of time, physical exam, therapy. You need a professional there. You don't have to. Those are fixed procedure, man. You can automate it. You can using AI today. You can look at this guy's face. You can look at his movement. You can look at voice. Richard say, they know very well. You can automate that process. Free the physician and caregiver to do something directly in the bed, in the patient bedside. Direct the patient. Don't take away the time. We are at least in US, we're limited number, not enough specialists around.
Right.
I think you can AI. So we are doing some automation, AI automation, to do virtual physical exam, to do virtual physical therapy, to do post-treatment monitoring on the diet control. These are two areas where we try to implement it.
Great. Now, Richard, your closing thoughts or your ideas.
Yeah, so, I mean, for me, this is, the work we're now doing with a number of major organizations is that we're trying to get the organizations to accept the fact that they are told an awful lot by their patients or by their customers that they just choose not to listen to, right? They don't have the AI, they're not listening. And these customers over time, 6 months, 12 months, multiple conversations, you can learn so much more about the state of an individual by just doing that, doing nothing other than that. If you've got video as well, that helps. So you can tell a lot by just looking at somebody and how they're feeling. So if coming out of that, you get a much more rounded understanding of the person you're dealing with, that I think is not absolutely revolutionary, but it's a good starting point. Really understanding the people you're dealing with in the broader context, and then applying whatever you need to apply. I think that for me is the work that we'll be doing more of over the next 12 months.
Great thoughts. Nicole, your final thoughts, perspectives.
Wow, so much. So I think both Steve and Richard were alluding, especially Steve, to I think what gets referred to in the industry as deep medicine or deep learning medicine, where you've got AI and deep learning augmenting a doctor so that they can spend their brain doing the right things and not wasting their time doing stuff that's fairly mundane. I would say we're essentially investing in trying to make the platforms that are as cohesive a view of data to enable those types of engines as possible. And so, because at the end of the day, we sit right between payers and providers. It's rare that they have data that feeds back and forth in a meaningful way, but we aggregate quite a bit of that data together because we sit between them. So between EHRs and claim systems, and it's just the IoT we don't have, honestly. But so trying to enable that vision of deep medicine, I think, is definitely a part of our goal set for sure.
No, great thoughts. The only thing I would add that I think that we're really trying to focus on is just trying to get a deeper, leveraging tools like AI to get a deeper level of engagement with our members and try to understand what their needs are and build that needs assessment. And then we can actually, do some interventions to help really address their social needs, their medical needs, their engagement needs. I don't think we have that figured out yet. A lot of folks, at least within the Medicaid space, are hard to reach, hard to engage. They're not familiar with the health system and all of its complexities, which, to be honest with you, I think all of us have challenges sometimes when engaging with the health system.
Yeah.
But that would be my final statement on that. I can tell you this has just been a great conversation. I really appreciate you all for sharing your thoughts, and it's been extremely rewarding. And I know the folks listening have enjoyed it as well.
Great.
Thank you much, John.
Thank you very much.
Thank you, John. Thank you for your time.
Yeah.
Thank you, Richard, Nicole, John.
Thank you, Nicole. Thank you, Steve.
Thank you all so much. Thank you to all of our amazing panelists, and a special thank you to John for moderating. This has been an awesome conversation. And like you said, the audience is definitely giving you a huge virtual round of applause.
Thank you.
All right, for the audience, it's time for you to make your way to your next session. Along the way, make sure you accept your connection request and check out our amazing AI exhibits. Thanks so much, and we'll see you around.
Bye-bye.
Thank you. Bye-bye.